lady, promise. I'm so excited for this. All right. Anthony, thank you so much for scribing. Andrea, thank you so much for doing teaching points. So if you guys want to get the screen up, we can get started.
Okay, let me know when you're ready.
Sure thing.
So this is a 25-year-old female with weakness and shortness of breath.
Wow. What a start already. Okay, I'll pontificate for a little bit and then pass the mic to our G. So a weakness and shortness of breath, I think a couple of things that would be really, really helpful is we know already that this is a young woman that is coming in, is getting a better understanding of the time course. With weakness, the most important thing for me is to is this asthenia? Is this generalized weakness because of something else that is going on? Or is there anything that evokes a neuromuscular pathology that we need to further think about? And with shortness of breath, how about I just pass the mic to RG and then we'll hear some more.
Wow, I love that. I think that the thing that's grabbing our attention is the shortness of breath because of its morbidity. And I think that if you're thinking in real time, you'd probably be focused on the shortness of breath because it's a much more morbid symptom. But I think the only thing that's different apart from the only thing that's different in our usual invoking of the dyspnea pyramid, which is heart, lung, and other, is to say, well, what does the weakness tell us? Does the weakness just tell us that this person is tired because they have a systemic issue that also causes dyspnea? Or is this a morbid presentation of a neurological disease that has resulted in dyspnea? So that you'd be able to tease out very quickly if the patient has any evidence of neurological weakness elsewhere. So say this person turns out to have, oh, my legs are weak and I can't breathe. You're probably jumping to neurological causes of dyspnea. But if somebody says, hey, I'm just feeling really weak and I can't breathe, you probably would say that the weakness is a bystander and the dyspnea is the cause. All of that comes with the assumption that a neurological cause will leave a signature outside the respiratory tract. And you have to be careful because there are some neurological disease like high cervical spine disease that can only present with neuromuscular compromise of the diaphragm. So realistically, we're just dealing with somebody who's short of breath, who has asthenia, probabilistically speaking. Less likely, we're dealing with a neurological disease that is manifesting as neuromuscular weakness. And most concerning would be, most prone to diagnostic error would be an isolated weakness of the diaphragm, which leaves no sequela elsewhere. So what would I do in real life? I would try to tease out if there's a neurological component, but I would do something I wouldn't otherwise do, is I would assess for neck muscle strength in this patient. Because neck muscle strength correlates with diaphragmatic innervation and might be a quick way to avoid that final scenario where we'd be most set up for a diagnostic error. Alrighty, I'll give the mic to you, promise.
Great discussion. Okay, so for HPI, the onset of symptoms started about 1 week ago, and she also noted generalized weakness. Dyspnea is exacerbated on exertion, but relief with rest, and she denies chest pain. And I can also go ahead and go for past medical history if you want.
I see that Charmaine might have been pulled away. I'll just say, what does this do for us? I think the fact that the weakness is generalized makes a neurological cause a little bit less likely, but does not rule out a generalized neurological disease like a myopathy. The fact that her dyspnea is present only on exertion doesn't provide any specificity within the dyspnea pyramid. It just tells you how bad it is. So all the things on the dyspnea pyramid, cardiac, lung, or other, begin with dyspnea on exertion and then ultimately end with dyspnea at rest. So there's no specificity to this. It just is a barometer. Dyspnea on exertion is much less severe than dyspnea at rest. So what we've probably moved closer to we've probably moved further away from a neurological cause, but the dyspnea on exertion doesn't change the diagnostic calculus. It just changes the amplitude of the disease severity. Anything to add to that, Charmaine?
No, that was brilliant as always.
Okay, so the past medical history is interesting. There's a pilonidal cyst drainage 3 months ago with a 10-day course of doxycycline. And then she had an IUD placed 2 months ago. There's no significance with family history. Also, she denies alcohol, drug use, and tobacco use. And with associated symptoms, she had a longer menstrual cycle this month. It lasted 12 days as opposed to usually 5 days. And she has a new IUD placed 2 months ago and is non-hormonal. And with review of system is significant for fatigue and weakness. She has intermittent palpitations and then no rash or pruritus. Everything else is normal.
All right, thanks so much, Promise. So just kind of thinking about the past medical history and kind of again going back to her chief complaints of like this dyspnea and exertion and how we can like tie them together. So if she had a cyst drainage, she was on doxycycline, every time there is a cut in the skin of some sort, then you have to worry about infection, and for whatever reason, a metastasized infection that can potentially have septic emboli to the longest component of it. But again, that is a stretch, but that's something that invokes in my mind. And then the IUD, so she got a non-hormonal, which I presume is like the copper IUDs. And with the copper IUDs, women tend to have a longer and like more severe bleeding, although it's not hormonal. So her complaint of like, and now that she's having a longer menstrual cycle, getting about would be important to get better sense of like, during her menses, like how much blood loss is she suffering, how many pads she's changing, all of that to get a sense of like, hey, is what we're dealing with this dyspnea and exertion, this weakness, are we dealing with like anemia in a young woman? And the other things too, I think about as well, always a good in a young woman to get a sexual history as well, thinking about again like disseminated infections that you have to worry about. RG, what else comes to your mind?
Zero. I just wanted to acknowledge, since there's a few seconds of time, that Promise is a preclinical student who is doing human DX cases in her spare time. Let that sit with you all about the epicness of the human being presenting a case to us. I think we're ready for more information in this case, Promise.
Oh, Rafi, thank you so much. I'm honestly shaking while presenting. So thanks for bearing with me. But for physical exam, vitals, her blood pressure is 108/63. Her heart rate is 112. Respiratory rate 16 and 99% O2 sat. And her temperature is 36. And for chest X-ray, they didn't find any acute cardiopulmonary disease. And I can also go ahead and reveal labs if you want.
I know one of the biggest drivers of 30-minute VMR is to be authentic to the moment. And I was waiting for the exam. I was waiting for the exam to welcome Aisha, who actually I've never ever seen. She has her video turned on. Hello. It's nice to see you. Aisha is one of the, I think, the biggest supporters of CP Solver's efforts, Patreon, Twitter, and whatnot. So thank you for joining us today. I just wanted to say that a simple point: most causes of shortness of breath live in the thorax. Whenever you look at that pyramid, we say heart and lung, right? And so the question is, how good we are at with our exam and our basic evaluation of EKG and chest X-ray at picking up those thoracic causes? And the answer is very good. You'll hear the crackles of heart failure. You'll pick up the MI on EKG. You'll see a pneumothorax on X-ray. So the hard question to ask yourself as you're starting to look at dyspnea from a practical lens, like the one that Dr. Costa has to do in the resuscitation unit, which isn't so much what is the cause, it's what does my initial evaluation get me and what does it not get me? What can sneak up within the thorax that bypasses your initial evaluation of an X-ray, a physical exam, and an EKG. It's issues with the plumbing. So you'll miss a pulmonary embolism. You can miss ACS and acute coronary syndrome, plumbing of the vessels. You can also miss some subtle airway issues like vocal cord disease. But more importantly, what if PROMIS's initial evaluation is negative, what you're more likely to miss are the rare but important extrathoracic causes of shortness of breath, namely the diseases that don't just live in the chest. Those are things like metabolic acidosis and anemia, where you need your blood work to come back 1 hour later, as opposed to your EKG and your chest X-ray, which come back much quicker. Things like thyroid issues, neuromuscular weakness, carbon monoxide toxicity, all of them are diffuse diseases. So when I'm evaluating a patient with shortness of breath and I don't pick up anything on my exam and initial evaluation, my priority is to wait for the blood work to come back to tell me if the patient's anemic or acidotic. And then if that's not true, I'm starting to think about the plumbing. Do I need to get a CTPE, or do I need to think about a repeat EKG and a troponin with a patient with ACS? So this is a great case to remind us of that, because so far we've seen no signature of the disease in the chest with our exam. And the question will be, will we get an answer with a chest X-ray EKG? If the answer is yes, we're done. If the answer is no, look at the blood work. And if the answer doesn't emerge in the blood work, we're going to have to get a CTPE or think about EKG and troponin. So that's the train that we think about in terms of evaluating the patient. We'll see what stop PROMIS has in store for us today.
Wow, thank you so much for all that pearls, Robbie. That's amazing. Okay, so for labs, her white blood cell counts is low at 3.6 thousand. And then segmented neutrophil is 22%, lymphocytes 67%, and monocytes at 2%. Her hemoglobin is very low at 4, and her MCV is high. And then she has slight anocytosis, a few microcytosis, and a few ovalocytes. And then her platelet count is low, and her reticulocyte count is 4.2%. And then for the sake of time, I would just review the iron labs too. So the iron study, ferritin is high, 286, transferrin is 233. Her iron level is 220, and her total iron binding capacity is 347. And then the iron saturation is 63% with haploglobin at 47. And then the INR is 1.2, and folate and vitamin B12 levels are normal.
Well, whoa. No wonder this, she's feeling bad and short of breath and really tired. She has anemia to 4. And it kind of like tells you about kind of the resiliency of the human body and also the tempo of this as well, is that, like, you know, she's like a little tacky, like her blood pressure in the 110s, right? And for like a young woman, that's not, doesn't strike as too much of an abnormal blood pressure. And now we see like a hemoglobin is 4. So kind of thinking about the time course as well, just like given her hemodynamic stability, like I probably put this as a more of a subacute type of a blood loss that she's been suffering from, because she remains like hemodynamic stability. You know, if this was like really acute, then your body wouldn't have enough time to be able to balance it out. So in terms of like the acute anemia, blood loss is usually number 1, number 2, number 3 that we think about. Also, like hemolysis is another thing to consider in people. Her macrocytosis, when your bone marrow is really, really hard at work and it's healthy, you can get macrocytosis because your bone marrow, your factory is just working really, really hard to reproduce some blood as well. So I do wonder if that might be one of the case in the setting of a folate and iron that is normal. I looked in anemia, and the haptoglobin tends to be a very specific marker for hemolysis is negative. The other things to think about is like on your liver chemistries when blood is like hemolyzing, then all the initial content gets out. So you have usually elevated ATH, your potassium, ability, those things tend to be elevated as well, which we don't have the data here, so I assume it's negative. The other thing to kind of think about, type of anything that can suppress your bone marrow acutely, like aplastic anemia of some sort, that can lead to an acute anemia that is less likely. It tends to be blood loss, then hemolysis, and then a bone marrow suppression. And when it comes to like thinking about like acute blood loss, where can that blood go? In a menstruating woman, we know she's having heavier bleeding. So that is one area to think about. Your GI tract, your thighs, your lungs, we didn't see any pleural effusions, we didn't hear anything, tend to be the places that you can hide in your intra-abdominal retroperitoneal. So those are the places that you want to think about. RG, what else?
What else? That's like the hardest question ever. I have nothing to add. I think the key question is where is the lesion? And I think you have to make sure that you're not assuming that it all comes from one place. Is the thrombocytopenia resulting in bleeding? Is that the cause here? Or is this just a case of pancytopenia from the same cause? The reticulocyte count is not as high as you'd expect it to be, pointing to a hypoproliferative cause, such as diseases of the bone marrow. But the problem is that it may be on the rise. And so it may be falsely low and go higher and higher and higher. So I think practically what you do in this case is you want to understand, is there any system involved outside the hematological system? So say you scan this patient and you see lymphadenopathy and you see a dominant disease elsewhere that prioritizes invasion of the bone marrow. If you don't see disease anywhere, it probably is something within the marrow itself. So I think, what would I do in real life? I think you have to think about trying to understand what is the center of gravity. And if the pancytopenia is the exclusive focus of the disease, then it becomes much more likely that it is a disease of the bone marrow or impaired hematopoiesis. Yeah, other than that, I don't think I have anything to reflect on. Right,
can I just say something? I totally didn't see that playlist for low, and that's great because you can definitely see how the discussion changes, right? From like thinking about anemia as a center rather than pancytopenia. And Robbie pancytopenia, and I go way, way back. That's awesome. That's my cognitive autopsy. It's like, look at all the labs before you talk. All right. Promise, back to you.
Okay, so additional lab shows that the viral hepatitis panel is negative, HIV is negative, mono is negative, parvovirus B19 antibody IgGs reactive at 1.15, and then the PNH flow cytometry is unremarkable. And then after this, I can review the bone marrow biopsy.
All right, I'm really glad that y'all got a bone marrow biopsy, because at the end of the day, I think you're accumulating more and more data that the disease lives within the marrow. And the question there, if you're asking about diseases within the marrow, is it a problem with the stem cell itself, or is it a problem with the process required to convert a stem cell into a mature cell? So if you're there and you're confident that your patient has a bone marrow problem, think about it in one of two ways. Is it a disease of the stem cell, or is it a disease of the processes required to transform a stem cell into a mature cell? There are only really three important diseases of the stem cell. They are in order of acuity: acute leukemias, aplastic anemia, and myelodysplasia. There are other ones too that are much less common, but those are the three common ones. Acute leukemia being the most acute, aplastic anemia having the potential to be acute, but often subacute, and then MDS, which is almost always chronic. Those are the three dominant diseases of the stem cell itself. But then a stem cell doesn't magically transform into a mature cell. It requires four things. It requires necessary nutrients like B12 and folate. It requires hormones. Those hormones, some of which are understood, but some of which are not. Important contributors are TSH, testosterone, and many pituitary hormones. In fact, panhypopituitarism is a common cause of pancytopenia, but it's usually mild, so not appreciated. So it requires these two things, and it requires the absence of toxins or medications that can inhibit this process. So examples of toxins are things like alcohol and arsenic, and examples of medications are plenty of medications like methotrexate. So here, there's no medications or toxins that played, and the patient's not having any evidence of hormonal issues or having any evidence of raw material deficiencies so far, but you should look for those. So the focus is on the stem cell. And so the question is, what is she at most risk for? I'd say that MDS is unlikely in younger people absent a family history. So the question is, does she have leukemia in her marrow, or does she have aplastic anemia? The parvo positivity here could be a red herring. Aplastic anemia has many secondary causes, though most aplastic anemia is idiopathic. But one of the causes is parvovirus infection. And so here the parvovirus antibodies can be secondary to previously acquired infection, or maybe a clue that she recently acquired this infection. And so that's when you have to go back and ask her if she's been ill herself or been around maybe children who've had parvovirus. But I think no matter what, the practical is you need to do a bone marrow. And the bone marrow will be very, very helpful in this case. I see that Charmaine's doing some clinical stuff, so I'll pass the mic back to you, Promise.
Okay, so the bone marrow biopsy shows that it's a very hypocellular bone marrow, and there is no immunophenotypic evidence for lymphoproliferative disorder, acute leukemia, myeloid disorder, or plasma cell neoplasm, and it's negative PCR when they did a parvovirus B19. So I think you nailed it, Robbie. The diagnosis is aplastic anemia.
Thoughts, Charmaine? I don't know if you had to.
Yeah, no, I was sorry. It's a busy morning here in the hospital. Sorry for going back and forth. I promise you were absolutely right. This is a really great case. Thank you so much for sharing it and presenting it so beautifully. And yeah, what a fantastic discussion. RG, what are your thoughts?
Give me 1 second. I'm gonna pull something up to share with you all. Yeah.
And can I also just shout out everybody in the chat? What freaking brilliant discussion. I always learn so much from all of you in the chat. So thank you so much for sharing your thoughts as RG is pulling that up.
I couldn't agree more. I think pancytopenia comes with the cost of you assuming that everything comes from the same source. But you could just have anemia from thrombocytopenia. But if you assume everything is happening because of the same reason, the key question is, are you losing all your cells? Do you just have impaired synthesis of that stem cell? Or is there something invading your bone marrow? And the key clues before you start to think about which one it is are to know what the time course is, what the center of gravity of the disease is, what the smear shows, if they're high or low retics, and maybe some other things here or there. This case is a very strong case for impaired hematopoiesis. Why? Because if you just look at the center of gravity of increased loss and myelopathy, it's systemic. So patients with increased loss are people who have tick-borne disease or lupus or very hectic fever, cytopenias in the ICU. Myelopathy is the same. Patients have disease elsewhere that invades the bone marrow. So as soon as Promise told us her only problem is pancytopenia, it became clear she has an impaired hematopoiesis problem. And whenever impaired hematopoiesis problem comes out of the blue, it's probably aplastic anemia, because leukemia won't come out of the blue. You'll have blasts in the periphery, you'll have coagulopathy. MDS doesn't come out of the blue, it's very slow. You're not going to look at somebody who has such deep pancytopenias from B12 deficiency and folate deficiency and not have a clue that there's some sort of nutritional disorder. So I think if you're shocked by somebody having this deep a pancytopenia, the chances of it being aplastic anemia are 90%. That 10% is humility that you may not have appreciated some subtle cause. But really, anytime that you're like, oh my gosh, I can't believe this person's pancytopenic, it's probably aplastic anemia, or we haven't done our due diligence in making sure that there isn't some subtle systemic signature, or that the patient has a microscopic, like the patient's only not eating B12 and otherwise has a great diet. You know? So I think this case is a really good example of that concept, and I'm really grateful that Promise brought it here today. What did you learn from this case, Promise?
My initial differential was all over the place, and I was like really thinking about the neuro cause because just how young she is, and also like the cardiopulmonary. So I'm really glad you brought up the teaching point of like thinking about like once you found out that the cardiopulmonary from physical exam is normal, then you like completely switch to thinking about the blood, because I honestly didn't think about anemia causes in the bone marrow until I saw the labs. And I think just seeing how the diagnosis kind of takes a turn was like something that I took away from this case. Yeah. But also everyone had like such a great discussion. I learned so much. Thank you.
Thomas, I wish I was as good as you when I was a second year medical student. You're fantastic. That was such great reflections too. All right, Andrea, I think we're ready for you.
Hi, thank you. We started thinking about the cause of the weakness. It was a generalized weakness, or it was something muscular. And a pair was that if you evaluate the neck muscle strength, it can inform you of the function of the diaphragm. And in cases of shortness of breath, we tend to think first about thoracic causes like hair or lung, but you can miss extrathoracic causes like anemia, neurological disease, CO, and thyroid. The dyspnea only on exertion gives you an idea of the severity, but it's not specific to certain diseases. Something good to know is that Cooper IUD causes longer bleeding during periods. Because this patient was hemodynamically stable, she may have had acute blood loss. So we think about the causes that will suppress the bone marrow. When we see a case, we try to always think of a center of gravity. In this case, it was the pancytopenia. And then we thought, is this a problem with the stem cell or a problem with the process of the stem cell to become a differentiated cell? So the most common bone marrow diseases based on acuity are acute leukemia, aplastic anemia, myelodysplasia, and also it's good to know that there are external agents that can cause pancytopenia, like alcohol, arsenic, and methotrexate. And normally the most aplastic anemia is idiopathic, but it can also be secondary to infection like parvovirus. And a secret thing about aplastic anemia is that it's normally impaired pancytopenia that comes out of the blood. That's a good tip. Thank you very much.
Thank you, Andrea. That was absolutely superb. Thank you for focusing our initial pre-aplastic anemia pearls in addition to the ones. Folks are talking in the chat about treatment, and treatment for aplastic anemia usually is varying degrees of immunosuppression, starting with simple immunosuppression, and if that doesn't work, consideration of transplant. So it is a very, it's a very, very tricky disease to have, but way better than the morbid possibility of leukemia. All right, well, thank you, Antonio, for prescribing, and Promise for presenting, and Charmane's working on a very complicated discharge, so I hope that goes well for you, and we'll hope to see you all. Just in case you're tuning in today, tomorrow, we're starting RLR an hour earlier, so we're going to be at 8 a.m. Pacific time. Hope to see you there. Bye.